Doug Fuller is one of the senior analysts with us and really leads the data management and analytic activities with respect to the DOPPS Practice Monitor. Doug will present on trends in anemia at this point. Doug.
Hello, everyone. Thank you, Bruce. The first couple of slides I'll go over relate to dialysis prescription and dose. The first slide here looks at trends in single-pole KTORV over the DOPPS Practice Monitor period starting in August 2010 through the most recent data here is through April of 2016. We did see over 2012, there was a 2012 and 13, there was a brief increase in KTORV with a little more tapering off and perhaps a slight decline in the most recent data in 2015. The proportion of patients with KTORV less than 1.2 has declined from 7, 8, 9% down to 4 to 6%, which suggests that patients and facilities are meeting their KTORV targets, which are also influenced or have influence on reimbursement and payment paradigms in the U.S. Next slide. Looking at the KTORV breakdown by DO size, we can see that generally the DOs tend to be comparable in the most recent years, with about 45% of patients above 1.6 and 95% of patients above 1.2. However, in the past, this does reflect a small decline on the part of the large and medium DOs, which previously had 52%. In April 2013, 52% of patients above 1.6. Next slide. Looking at dialysis session length, so treatment time, the amount of minutes in this case that the patient is dialyzing in the unit. Again, going along with the increase and later tapering and decline of KTORV, you see an increase in dialysis session length from 217 minutes up to a peak of about 220 minutes. Not a very large increase necessarily, but an increase nonetheless. But it's fluctuated. There may be some small seasonality effect going on in the most recent year and a half, fluctuating between 218 and 220 minutes in general. The proportion of patients with short treatment times less than 3.5 hours has declined from 34 or 35% down to now 31% in April 2016. Next slide. The prescribed blood flow rate also shows a similar pattern to KTORV, and of course, session length and blood flow rate are inputs to KTORV, so this is not surprising, perhaps. But blood flow rate has swelled to 428 mLs per minute toward the end of 2012, but then has declined back to 420 by the end of 2014, and is now sitting around 425 mLs per minute overall. Now, I should note that DOPPS 6, which began in April of 2015, may explain some of the brief increase from 419 to 423 between December 14 and April 2015. Looking at continuing units, the decline, looking at the mean blood flow rate among facilities that were participating in both DOPPS 5 and DOPPS 6 suggests that the blood flow rate has not actually changed dramatically in 2015. Next slide. So moving on to anemia, the prescription, we threw the poll questions in here. On your screen, you should have 4 poll questions, mostly dealing with the introduction and use of Mircera in your facilities. So we would like to know if in your practice patients are now prescribed Mircera. whether or not you anticipate starting Mircera in the next year, how Mircera has influenced your hemoglobin levels in your unit, and as well as whether Mircera has influenced your use and quantity of IV iron in your patients. So over the 6 years of the DOPPS Practice Monitor, we have seen a slight decline in the proportion of patients using ESAs, and the blue line on the very top declining from 95% at the start of the period to currently 91% in June of 2016. And this is consistent with the introduction of bundled rate in January 2011, as well as prescription guidance from the FDA and other reimbursement-based influences during 2011 that I'll describe later as well. The increase that we saw in the use, the proportion of patients prescribed IV iron has been sustained throughout this period. Now 81% of patients are prescribed IV iron during the prior 3 months. With the transition to the bundled payment system and other ESA related factors, there was a hunch or a hypothesis that facilities may switch from IV delivery to subcutaneous delivery, and in fact we did see an increase over the last 6 years in the proportion of patients receiving their ESA through subcutaneous route, but this has been limited to usage in the non-LDO sample. This is obviously a facility practice. We've discussed in the past WebExes and past reports. This is primarily due to individual facilities moving the majority of their patients from IV to sub-Q rather than reflecting an average proportion within each facility. So before the bundle in August 2010, only 2% of patients were reported using sub-Q. That swelled up to as much as 37%, and a point that's available on the website but not on this graph, actually hit up to 40% in 2014, but has declined since then, back down to about 20% in June 2016. Next slide. One item of interest that we've been watching carefully with the DOPPS Practice Monitor is the introduction and uptake of Mircera use, pegylated epoetin beta in the United States. And this slide and several others are truncated going back to June 2013 because ESA type didn't change that much in the 3 years prior. But since March of 2015, we've actually seen an increase in both darbepoetin use as well as Mircera use in orange. So currently in June 2016, Mircera use is actually equal to that of epoetin alpha in the blue at 43% each, with the remaining 14% using darbepoetin. Okay. So on this slide, looking at weekly IV epoetin dose, keeping in mind that there's fewer patients receiving IV epoetin. This is epoetin alpha, not any ESA, epoetin alpha specifically. On the left side of the graph demonstrates the rapid decline in ESA dose that occurred in 2011, with median dose falling from 13,100 units per week down to 8,800 units per week. And even more strikingly, the 90th percentile denoted at the top of the vertical bar, 51,000 units per week down to 30,000 units per week. Since August 2012, roughly, the median values have remained stable, maybe bouncing around a little bit, but the median value has stayed between 7,000 and 8,000 units per week since August 2012. What we do note is that in the most recent year and a half or so, it appears that the 90th percentile doses are starting to come down further, that may reflect tendencies of facilities to try to put some of their higher dose patients on Mircera to see if that changes things, or just facilities that had high doses of ESA moving to Mircera outright, or simply reducing doses. We're still looking into this, and but we do find this to be an interesting development, recent development. Next slide. So concurrent with the decline in ESA dose in 2011, hemoglobin values fell quite rapidly from a median of 11.5 down to 10.8, 10.9 by the middle of 2012. In the box, you can see the trends there. The decline of 1/10 of a gram from August 2010 up until the prescription guidance was updated in July of 2011. And subsequent to that, the median declined 0.45 grams per deciliter, so over a 3 or 4 month period, so quite a rapid decline there. Since then, there's been a steady decline of 0.04 grams per deciliter per year. So what that means is very small changes in hemoglobin. On the right side of the graph here, you can see from June 2014 to the present, the median has stayed very flat, 10.8 grams per deciliter, no changes really in the other percentiles as well. And if I can get one more click, what's really interesting to note here is, of course, the introduction of Mircera into use in the United States in March of 2015, at least according to our data. And with that introduction, we have not seen any substantial changes, or even small changes for that matter, in the hemoglobin distribution. Now that said, this is all hemoglobin values, so but we've also not seen any substantial differences among hemoglobin values limited only to patients receiving ESA. Next slide, please. So this is basically the same information, looking at it categorically, and you can see that the equipment produced a metric by which facilities with a large number of patients with hemoglobin above 12 received reduced reimbursements. And so, as you might expect, that number declined very quickly from 31% down to 14%, and it's stayed about 14 or 15% since the beginning of 2012. Likewise, the removal of the quote-unquote floor of hemoglobin less than 10 has led to an increase in the proportion of patients with hemoglobin less than 10, which is denoted by the light blue and the yellow bars at the bottom. And that has increased from 8% in August 2010 to 18% in August 2012, and it currently remains at about 19% in June of 2016. So, Arbor Research has published a paper looking at the rise in ferritin that we've described in the DPM. The ferritin in 2011 rose from 604 604 nanograms per milliliter to 770 nanograms per milliliter in the median, and it's remained in the upper 700s. Now it's 790 in June 2016, and overall that's an increase of 31%. The paper by Angelo Caraboyas showed that this was largely related to facilities reducing their ESA dose, such that the iron requirements may have been lowered, and so without much change in iron delivery, so that ferritins had been increased. Next slide. And the increase in ferritin contrasts with relatively little change at all in transferrin saturation during the period of the DPM. The median has increased only 1 percentage point. When you round to whole numbers, it's 29. DSAT of 29, pretty much straight across the board. So that is the contrast to ferritin. And of course, in the most recent year, there's also been very little change. So to sum up on the next slide, we've seen Mircera use first observed in the DPM in March of 2015, now at 43%. We've also seen concurrent smaller increases in darbepoetin use, which was not very common, mostly used in hospital-based units. But in recent times, we've seen it outside of hospital-based units as well, now 14% overall. EPO alpha use, on the other hand, is now less than 50%, and EPO dose trend has remained steady at about 8,000 units per week. Maximum ESA doses are coming down as well. We haven't seen any, in the 90th percentile anyway, we haven't seen values above 30,000 units per week for several years now. And sub-Q EPO use peaked in 2014, but it's come back down to 19%. Again, this is a facility practice, so that's going to be perhaps a little more sensitive to facilities coming in and out of the DOPPS study as we change phases and as we progress. Mean hemoglobin levels have remained steady since 2012, 10.8 grams per deciliter, no change with the introduction of Sera, and the ferritin levels seem to be leveling off, but they remain elevated, and they stand in contrast to no changes. So to move on to the poll questions, thank you for responding. The first question: in your dialysis practice, are patients now prescribed Mircera? Looks like about 80 to 85% of patient responses were no. So a few patients are prescribed Mircera for some of you. Do you anticipate starting Mircera for more patients in the next year? That looks to be about 75% saying no, and a quarter saying yes. If your center is now using Mircera, are hemoglobin levels more or less stable? And as we've shown and confirmed by our data, the vast majority of responses here say no difference. And as well, if your center is now using Mircera, are using more or less IV iron than before, majority say no difference. So thank you for your responses. Thank you for your time. And I pass back to Brian.
Doug, thank you very, very much. I appreciate that. So continuing changes in the anemia space, particularly with introduction of new products, rise in ferritin that appears to have stabilized of late, but still I think of real importance with respect to trying to understand implications for patients. In the interest of time, I'm going to show just 2 slides from the mineral bone disorder section, and then refer folks to the slides afterwards if you're interested in more details. The first of these is that we've described for some years rise in serum PTH levels in the U.S., and it appears that those are still rising to some extent. And actually, this is more of an issue even among black patients than non-blacks, with 31% of patients now with PTH levels greater than 600. 18% of non-blacks. And again, those numbers are rising, so PTH levels are going up slightly still. If we look at the next slide, just to remind folks, this is a publication of ours, Dr. Tintori and all, and C. Jason last year, showing association of elevated PTH with elevated mortality, particularly at the 600-plus range. So that remains a practice trend of some concern here in this country. The other issue of note with respect to mineral bone is the trend in some centers towards use of oral 125, oral active vitamin D, so oral calcitriol or rocaltrol, and that slide is shown here. So that transition from IV to oral vitamin D is of real interest and merits additional study in the coming months as well.